Sensory perception is the ability to receive and interpret sensory impressions. That means that when we are taking care of our patients, they see and feel and smell and hear everything that's going on around them. And it's important for us to understand what those processes are and when there's a problem with those processes, when there's a deficit in sensory perception, so that we can help our patients in the best way possible. Humans have 5 basic senses: our sight, our smell, our hearing, our taste, and our touch. When a patient has a sensory alteration, that means there is a problem with how they see, smell, hear, taste, or feel. Sensory information is processed through the central nervous system. When we taste or hear or smell or touch or see something, that stimuli is sent through sensory organs to the brain, which receives the information, processes it, and generates a reaction. If we place our hand on a hot stove, the senses go up to our central nervous system. Our brain tells us that it's hot, and we quickly remove our hand from that painful stimuli. If we have a disruption in how we sense or how we react to those sensations, that can affect a client's well-being. Sensory input is received and transmitted to the brain via 12 cranial nerves, which we'll learn in just a little bit. These cranial nerves control both sensory, so how we interpret stimuli, and the motor function, how we react to that stimuli, of the head and neck. If we have dysfunction of a sensory nerve, that can cause sensory alterations, such as deficits, deprivation, and overload. These alterations can be caused by age, medications, inquiries, neurocognitive disorders, or disease. When a client has a deficit in the expected function of one or more of their 5 senses, it's called a sensory deficit. For example, if a person cannot hear sounds below a certain decimal level, they are considered to have a hearing deficit. Sensory deficits can occur because of injury, illness, or aging, and they have significant effects on our patients' well-being and daily functioning. Sensory deprivation occurs when there's a reduction in or an absence of stimuli to one or more of the 5 senses. An example of sensory deprivation is blindness, which causes an absence of visual sensory stimulation. Loss of hearing is also considered an example of sensory deprivation. Sensory overload is defined as receiving stimuli at a rate and intensity beyond the brain's ability to process the stimulation in a meaningful way. There's just too much of it going on. This can cause our clients to feel anxious, restless, or confused. The example your book gives is a client who's in the ICU, they're critically ill. They might be in pain frequently. They're getting multiple sensory stimuli, from the bright lights to the machines that are beeping, and from their own body, whether they're uncomfortable or they're having pain. And then they're going to be interrupted by nurses and providers very frequently. When a client appropriately detects sensory stimuli, but their brain has difficulty interpreting it and responding appropriately to it, the client is experiencing sensory processing disorder. They are getting the sensations, but they just can't figure out what they are because they are so overloaded. Clients with sensory processing disorder are oversensitive to normal stimuli, like the noise of a car driving by or the light touch of a shirt against the skin. These common stimuli can then become physically painful or feel overwhelming to the client. Sensory processing disorder is usually discovered during childhood, but it can affect adults. It's more often in clients who have developmental conditions like autism, ADHD, and obsessive compulsive disorder. This slide shows us our 12 cranial nerves. It tells you the numbers for each nerve, 1 through 12. It tells you what the function of that nerve is. And those functions can be sensory or they can be motor. So it can cause our body to move, that's our motor, or it can cause our body to interpret stimuli. That's going to be a sensory nerve. And then we've got tests that we can perform on our patients to make sure that those nerves are working properly. So it's important that we memorize and understand what the 12 cranial nerves in the brain do. So this slide gives you some easy ways to remember what each cranial nerve does, whether it's sensory or motor, and what the name of the nerve is. So the cranial nerves are the olfactory nerve, the optic nerve, the oculomotor nerve, the trochlear nerve, the trigeminal nerve, the abducens nerve, the facial nerve, vestibulocochlear, the glossopharyngeal, the vagus, and the spinal accessory or hypoglossal nerve. That's a lot to remember. But you can use the acronym OOO to touch and feel very good velvet ah. The first letter of each word in that sentence corresponds with the name of the cranial nerve. They also go in order. Next, I like to use the picture of the face to tell me what each of those cranial nerves do. So you notice the face is made up of numbers. That is how the face is drawn. The placement of the numbers can help you to remember what each nerve does. So the number 1, that is the nose, that helps you remember that it's the olfactory nerve. That's the nerve that helps us to smell things. If there is a problem with nerve 1, we won't be able to smell different substances. So the test for that is going to be to smell coffee or to smell an alcohol wipe and be able to identify it. Then we know that that nerve is working correctly. The second cranial nerve are our optic nerves. And if you notice on the face, those are drawn as 2 eyes with the number 2. That tells you that this nerve is responsible for vision. The way we test this nerve is by checking the pupils for size and alignment. We can also perform a visual acuity exam with a Snellen eye chart. That is the chart that you recognize that has different letters on each line, and you have to read the line, the smallest line you can. That is called a Snellen chart, and we use that to assess the function of cranial nerve 2. The third nerve is the oculomotor nerve, and that is written as 2 3s on the face in the shape of eyebrows. The oculomotor nerve is responsible for 4 of the 6 extraocular eye muscles. It also is responsible for constriction of the pupils and lens modification. To check this nerve, we can assess the pupillary reflex with a pen light. We can look at the eyelids for drooping. If the eyelids don't lift when you ask the patient, that could be a problem with cranial nerve 3. Then we also use our cardinal gazes to look to the upper right, look straight up, look to the right. That can tell us if those ocular nerves are working. The fourth cranial nerve is our trochlear nerve, and that is written as 2 little 4s kind of under the nose on the face. The trochlear nerve is responsible for looking down and out. So again, we can use those cardinal gaze patterns when we create that star that they have to look at in all directions. That can test to make sure their trochlear nerve is intact. The fifth cranial nerve is the trigeminal nerve, and that is responsible for sensation of the face. So that is drawn as a large 5 all the way across the face. We test that cranial nerve by using a cotton ball and seeing if they can close their eyes and tell where you're putting the cotton ball, on the forehead, on the cheek, and on the chin. Number 6 is the abducens cranial nerve, and that is responsible for abducting the eye. So again, we test that nerve as well by having our patients look down and to the outside. So that is represented by 6s on the face in that direction. Our 7th cranial nerve is the facial nerve, and that helps the muscles with facial expressions. It talks about taste on the anterior tongue and salivary glands and our lacrimal glands. We test this cranial nerve by asking an individual to smile and frown. And on the face, it's represented by the large 7s that make up the entire face. The 8th cranial nerve is the glossopharyngeal nerve. It's responsible for taste on the posterior or the back of the tongue, and it's responsible for baroreceptors in the carotid artery. So the way we test the glossopharyngeal is to assess their gag reflex, and that is written with the 8s near the ear. Just kidding, that was totally wrong. The 8th cranial nerve is going to be our vestibular cochlear nerve, and that's the 8s that are the ears on the face. So as I was saying it and looking at the face, I knew it was wrong. That is responsible, so the ears, where the 8s are, that's responsible for hearing and vestibular function. So we can rub our fingers outside the patient's ear, and that can test their hearing. Or we can do a whisper test to check their hearing to make sure that cranial nerve 8 is intact. Apologies. Cranial nerve 9 is going to be the glossopharyngeal, which has the taste on the posterior tongue, and that's where we're going to test it with that gag reflex. So if you notice, the 9 is on the back of the tongue on the facial picture, so that means gag reflex. Cranial nerve 10 is the glossopharyngeal nerve. Nope, that's 9. Sorry, these are hard. You're going to have to memorize them. Number 10 is the vagus nerve, and it is represented on the middle of the tongue in the facial picture, and that is also assessing the gag reflex. So you can get 9 and 10 doing the gag reflex on the patient. The number 11 on the face is written by the shoulders. That's the spinal accessory nerve. And the way that we test that is by having a patient shrug their shoulders with our hands on the shoulders. They can do that, then we know that cranial nerve 11 is intact. Finally, the 12th cranial nerve is called the hypoglossal nerve. And we can test that by making sure that a patient can stick out their tongue and that it's in the midline and that their speech is clear and articulated. So we can use the OOO to touch and feel very good velvet ah to remember what the cranial nerves are, the names of them. Then we can use that face to tell us what each nerve does and what number each nerve is on the face by where it's drawn. And finally, we need to know whether the nerve is sensory, whether it intakes sensation, or if it's a motor nerve, which causes us to move around. And some nerves can be both. So the memorization trick for that is, some say marry money, but my brother says big brains matter more. Now, the first letter of each of those words, there's 12 of them, is an S, an M, or a B. So that means the S's for some say are going to be sensory nerves. So 1 and 2 are sensory nerves. Marry money, that's your oculomotor and your trochlear. Those are going to be motor nerves. And then you've got your trigeminal nerve, which is both. So that is the word but. And big and brains, those are going to be both. So if you can memorize OOO to touch and feel, some say marry money, but my brother says big brains matter more. And you can remember the face, you're going to get 100% on the cranial nerves every time. So there are conditions that can interfere with sensory input, how we're getting that information into our brain. When we talk about vision, we can have different vision disorders which would alter the input coming in through our eyes. Light enters our eye through the cornea. It passes through the pupil to the lens posterior to the iris and then onto the retina. The retina will then send signals through the optic nerve to the brain to be processed and interpreted as an image. That's cool. The eye also has 6 extraocular muscles that help us gaze in different directions. There are different things that can cause alterations in our vision. So we've got some different vision disorders. The first one is called myopia, and that is the inability to see objects that are far away. It's also referred to as nearsightedness. So remember, it's the opposite. Nearsightedness means you can see near, but you can't see far. Hyperopia, or farsightedness, means you can't see the objects close to you well, but you can see the objects far away. Or you could have an astigmatism. That is where there's a defect in the eye that affects both near and far away. It causes things to look blurry or distorted. Those are very common causes of visual deficits. As we get older, we can get presbyopia, which is age-related farsightedness, and that usually begins in middle adulthood, and that means it's harder for us to see things up close. Hence, you see people wearing readers or magnifying lenses to help them with near objects. Cataracts are also a vision disorder, and that is when the lens becomes cloudy, and that causes the vision to be blurry, hazy, or less colorful. Cataracts can develop slowly and may occur in one or both eyes. People who have cataracts can have trouble reading, driving, or performing activities of daily living. The causes of cataracts can be previous eye surgeries, chronic diseases like diabetes, but mostly older age. In fact, by age 75, approximately half of all Americans have cataracts. Clients who have diabetes can experience damage to the blood vessels of the retina, which leads to blood leaking from the vessels. This condition is known as diabetic retinopathy and is the most common cause of impaired vision and blindness during adulthood. Diabetic retinopathy usually occurs in both eyes, but it can be asymptomatic in its early stages, meaning we don't notice anything is going wrong. As it progresses, we can see signs and symptoms like spots or floaters or blurred vision. Over time, unfortunately, diabetic retinopathy can lead to blindness. To slow the progression of the disease, clients need to maintain good control of their blood glucose level, blood pressure, and cholesterol level. So that means that any patient we take care of that has diabetes should have an annual eye exam to monitor for this disorder, diabetic retinopathy. Another disease that can cause loss of vision is glaucoma. So what glaucoma is an increase in intraocular pressure due to the buildup of fluid or aqueous humor, which is what that fluid is called, that causes compression of the optic nerve. So as fluid builds up in our eye, it starts to press against that optic nerve, causing problems. One of the first manifestations or signs of glaucoma is the loss of peripheral vision. That loss of peripheral vision can progress to include the entire vision field, leading to blindness. When you lose vision due to glaucoma, it's irreversible. However, progression of vision loss can be slowed or prevented with early detection and treatment. So that means it's important for our clients to have annual comprehensive eye exams. Manifestations of glaucoma can be severe headache, eye pain, and blurred vision. Those can require immediate medical treatment. You will be screened for glaucoma as part of your regular eye exam. They will measure the pressure of your eyes. They blow a little puff of air to, or they actually touch the lens to record the pressure. And that can tell us how much fluid is built up in the eye if the pressure is high. Another eye disorder is called macular degeneration. That is where the central portion of the retina can be disturbed. which leads to a loss of the central vision as clients age. So that vision right in the center of our visual field. Macular degeneration is the number one cause of vision loss and blindness for clients over 65 years of age in the United States. Macular degeneration blurs the sharp central vision, and that makes driving, reading, and seeing facial features difficult. Unfortunately, this disease is irreversible and its cause is unknown, but they believe that genetics and environmental factors may play a role in its development. Clients who have diabetes are at risk for that diabetic retinopathy. They are also at 2 to 5 times more at risk for cataracts and twice as at risk for having open angle glaucoma. So it's super important that any patient that has diabetes is getting their annual eye exam. Smoking can also increase the risk for cataracts and diabetic retinopathy. So as usual, we are educating our patients on the dangers of smoking. Here's that example of a Snellen chart that I was talking about earlier. If we suspect there's an alteration in vision, we should test them for a visual acuity. We can do that by having them read printed material like a book to ensure their near vision is intact, and we can also use the Snellen eye chart for distant vision. The Snellen chart measures how accurately the client can read lines of letters of various sizes. For clients who can't read or young children who don't know the alphabet, the tumbling E chart is used, and that's where all the letters are E's that face in different direction, and so the client can point their finger in the direction that the E is facing to get that letter correct. Whether you use the Snellen chart or the tumbling E chart, clients need to stand or sit 20 feet away from the chart, and with both eyes open, begin with the smallest line that they can see. Then we have the client cover up one eye at a time, reading the smallest line of letters they can see with each individual eye. When a client can read the line of letters marked 2020, it means they can see what the average person sees on the chart when they are 20 feet away. If the smallest line that they can read over on the left-hand side will give you those numbers. If the smallest line is 20/70, then they can see at 20 feet what most people can see at 70 feet. So they have a visual deficit. If a client wears glasses or contacts, we should test their visual acuity with them on and with them off, or out if it's contact lenses. It's recommended for children to have their first eye exam prior to entering first grade. If there's no family history of eye problems or vision problems, then those children should get an eye exam every 2 years until adulthood. Adults without vision problems should have an eye exam every 1 to 2 years until 65, when annual exams are recommended. For clients who have vision problems, eye disease, or a chronic illness that can affect vision or the structures of the eye, it is recommended that they have an annual comprehensive eye exam every year. Disorders of the eye or visual sensory system can cause errors in how the brain receives, perceives, and responds to visual stimuli. Errors in these processes can lead to visual deficits that can be minor or severe, from mild nearsightedness to complete blindness. Maintaining client safety and vision is the nurse's priority. Nurses can also educate clients about eye health and ways to prevent eye disorders, such as having regular eye exams, eating a healthy diet, maintaining blood sugar and blood pressure levels within normal reference ranges. Additional nursing interventions to promote eye health and assist in the prevention of visual deficits are discussed a little bit more later in this lesson. Ophthalmoscopy is where we visualize the back of the eye and we can see the optic nerve back there. The Snellen or Rosenblum tests are for visual acuity. Tonometry is where we measure intraocular pressure, and that can tell us if a patient is at risk for glaucoma. Goinoscopy visualizes the anterior wall of the eye, and slit lamp examination helps to look at the cornea and lens to see if there are any scratches on it. Interventions that can protect our eyes include wearing glasses to correct any vision deficits or contacts. We can take medications that can help the functioning of our eye, particularly if we need to lower the intraocular pressure because you're predisposed to glaucoma. Wearing eye protection protects the lens and the cornea, and hand washing ensures that we are not getting bacteria into the eyes causing infection. Hearing is another area where patients can have deficits. Hearing loss can occur in any portion of the ear or at any time during the lifespan. A client may lose hearing due to infection, injury, or from a genetic abnormality. The most common cause of hearing loss is aging, but loss can also be caused by exposure to loud noises like aircraft engines, motorcycles, factory, and construction equipment. When someone has tinnitus, that means they hear sound when no external sound is present. These patients are going to report hearing ringing, buzzing, roaring, clicking, hissing, or humming noises. Tinnitus can be caused by age-related hearing loss, an ear injury, an overbuilding of cerumen, which is earwax, or a blockage or a problem with the circulatory system. These noises can be high-pitched or low-pitched and may occur in one or both ears. There are 3 types of hearing loss: sensorineural, conductive, and mixed loss, which is both. Sensorineural hearing loss is the most prevalent type of hearing loss. That is when hearing loss occurs from problems either in the inner ear or on the auditory nerve. Sensorineural hearing loss can occur in newborns due to chromosomal abnormalities like Down syndrome or from a congenital infection, herpes, syphilis, or cytomegalovirus. Other causes of hearing loss in infants include preterm birth, low birth weight, low APGAR score, a history of neonatal sepsis, or hyperbiliuremia, which means excess bilirubin in their blood when they're born. That's usually from a liver issue. Childhood infections like mumps, measles, and meningitis can also cause sensorineural hearing loss, which is reason number 7,824 why we as nurses do encourage vaccinations for children. We don't want them to lose their hearing because of a disease that is preventable by a vaccine. Noise-induced sensorineural hearing loss has become more prevalent among adolescents and young adults from prolonged exposure to loud music and an increased use of headphones and earbuds. It can also occur in adults due to job-related exposure to loud noises over a long period of time. This is why lots of people will wear earplugs when they are mowing the lawn or when they go to a concert to help decrease their chance of getting noise-induced sensorineural hearing loss. Other causes of sensorineural hearing loss include trauma to the ear, heart disease, diabetes, meningitis, measles, and tumors on the vestibulocochlear nerve. Losing our hearing because of age is called presbycusis. Presbycusis is usually bilateral, so in both ears, and it's estimated to occur in half of all adults over 75 years of age. Side effects of some medications can be adverse and cause ototoxicity or damage to or dysfunction of the cochlea or vestibule. Ototoxicity from medications can cause sensorineural hearing loss, tinnitus, dizziness, or impaired balance. In pharmacology, you will actually learn which medications can cause ototoxicity so that we can make sure we are giving those medications safely and appropriately. When sounds can't travel from the outer ear to the eardrum and middle ear, that is considered conductive hearing loss. Common causes of conductive hearing loss include ear trauma, inflammation, impaction of earwax, perforated eardrum, or blockage by a foreign body. The sounds from the outside are not able to get to the inner ear to be interpreted. Otitis media is an inflammation in or the accumulation of fluid in the middle ear and can result in conductive hear loss. We can see this when babies get ear infections. In most cases, conductive hearing loss is treatable with interventions like antibiotics, anti-inflammatory medications, or surgery. Sometimes we need to place tubes in the little baby's ears so they can drain and the fluid will not accumulate. We can also get conductive hearing loss from an abnormal growth of bone in the middle ear called otosclerosis. This usually happens in early to mid-adulthood and occurs more frequently in women. So if we have a patient who has complaints of hearing loss, we need to figure out what is causing it. We can also have mixed hearing loss when they have a combination of sensorial neural hearing loss and conductive hearing loss at the same time. In pharmacology, you'll learn about the different types of drugs that can be ototoxic, which can be damaging to the ear and cause tinnitus or hearing loss. There's going to be antibiotics, diuretics, which are medications that make you lose water if you have kidney issues, NSAIDs, those non-steroidal anti-inflammatory disease drugs, and chemotherapy drugs. So we have to be very careful when we are administering these types of medications to our patients to be aware that hearing loss can be, or ringing in the ears, ototoxicity can be a side effect. When we are taking care of patients with hearing loss, we need to assess any communication deficits. Do they have a hearing aid that they need to put in? Do we need to use printed materials? We want to make sure that we face the patient. The area is well lit so they might be able to read your lips. We want to use brief, simple sentences, minimize background noise that could be distracting for their hearing. We always want to identify ourselves and make sure that we explain where things are in space. So for example, if a patient has a tray of food and they have a vision deficit, we can use that clock face to tell them where on the tray the food is located. So the potatoes are at 3 o'clock, the chicken is at 6 o'clock, etc. There are different types of hearing tests. The Center for Disease Control recommends screening for all newborns for hearing impairment before leaving the hospital. If the infant cannot pass the screening, they need to be fully evaluated by an audiologist in 3 or less months. Children at risk for hearing loss should be screened by 2 years of age. If they don't pass that hearing screen, again, they should be evaluated completely by an audiologist. The audiologist is going to perform several different types of hearing exams. The Rhine test helps determine if hearing loss is due to an issue with bone conduction or with the air conduction of sound via the auditory canal. So can they not hear the vibrations or can they not hear the actual tones? This test is performed with a tuning fork that is vibrated and placed against the mastoid bone. And the client identifies when they cannot hear the sound anymore. The tuning fork is then moved away from the ear and the client indicates if they can still hear the sound. That tells you if they can feel the vibrations and it tells you if they can hear the sound through the air into the ear canal. For school children, they like to perform a pure tone audiometry test to assess for hearing loss. That's where they have high and low pitch sounds that the students have to identify. Audiometry conducts sound through the outer and middle ear. That test helps detect the minimum sound that can be heard at different pitches or frequencies. During that test, a client is in a booth, they wear headphones, and they listen to various sounds at different decibel levels in each ear. The client will then identify when they hear each sound by holding up their hand or pressing a button. A tympanogram measures the mobility of the tympanic membrane, and otoscopy allows for visualization of the inner ear. If you look at the slide, you can see them performing the Rhine test for the bone conduction and air conduction tests of sound. Another sensory perception alteration that can occur is with speech. Disorders of speech impair the way that a client can communicate. Aphasia is a disorder that affects the client's ability to articulate and understand speech and written language. Aphasia can occur suddenly or appear slowly over time and is caused by damage to the part of the brain that controls language. This damage can be caused by a brain injury, degenerative neurological disorders, dementia, or a CVA stroke. There are different types of aphasia, and it's important for nurses to understand these different types so that we know the problem our patient is having in communication. Expressive aphasia is due to damage to the area in the brain, and that causes people to understand speech, but they may not be able to speak the words they want to say. So you can ask a patient with expressive aphasia a question, and they're going to understand the question, but they cannot form and speak the words that they want to say in response. They cannot express themselves. They may use short phrases like hungry now, and they can often become frustrated, especially if they're aware of their speech difficulty. It's really hard when you can't get the words that you want to say out, especially when you're recording a lecture like this. Ha ha ha. Comprehensive aphasia is caused by damage to another part of the brain, and that can make our patients speak in long sentences that have no meaning and often include unnecessary and made-up words. Wernicke's aphasia also causes a client to not understand what is being said, and they are unable to comprehend that others can't understand what they're saying. So in their mind, they are saying complete sentences, but what comes out of their mouth may be gibberish. And the third type of aphasia is global aphasia, which causes impairments in communication that can be severe. Again, it's caused by damage in different parts of the brain, but these clients can't comprehend language, and they may not even be able to form words or sentences. When a client does experience impaired speech, they can often we want to get their medical history, we want to do a neurological exam, we want to do any lab or diagnostic tests like MRIs of the brain to figure out what is causing the impairment. We can then have neurologists or a speech-language pathologist evaluate their language reception and expression and assist in determining the cause for the speech impairment. Patients may also experience alterations in their sensation of touch. Skin-to-skin contact at birth is usually our first mode of communication. We receive input or communication from the skin constantly when we eat, when we're exercising, even when we're sharing affection with loved ones. Even a simple handshake can be a form of tactile communication. Therefore, a touch disorder can have significant effects on a client's well-being. Touch disorders occur in the perception of stimuli, ranging from the inability to detect touch to the complex cognitive inability to recognize objects through touch. A client who has tactile hypersensitivity has a peripheral and/or central nervous system that is overly sensitive to sensory input, especially tactile stimuli. These clients may be unable to wear clothing that has a zipper or a shirt that has long sleeves. Sensory sensitivity to touch that most people would find acceptable is known as tactile defensiveness. Clients who have tactile defensiveness often experience physical pain with otherwise non-painful tactile stimuli, such as a hug, wearing clothing, or the feel of wind on their skin. These clients tend to avoid touch as much as possible and withdraw from tactile stimulation. It's also possible for clients to be under-responsive to tactile stimulation. If they have hyposensitivity, they may not be able to feel extremes in temperature or have a limited ability to feel pain from bone fractures or lacerations. That could become a safety issue. These clients may seek out tactile stimulation by frequently touching objects to figure out what they are. Alterations in touch have many causes. Common causes include peripheral neuropathy and spinal cord injury. So we've talked about this before, but peripheral neuropathy occurs following damage to or malfunction of a peripheral nerve. It most often affects the feet and hands, but it can occur in other parts of the body. Peripheral neuropathy signs and symptoms include weakness, numbing, tingling, burning, pain, inability to detect temperature, and hyporeflexia. We can also have idiopathic neuropathy, and that is due to nerve damage from an unknown cause. Idiopathic means we don't know what the cause is. Patients can also have diabetic neuropathy. That's nerve damage that occurs in clients who have diabetes. Diabetic neuropathy occurs over time from high blood glucose levels and high levels of triglycerides in the blood, which can cause damage to the nerves and to the small blood vessels supplying blood to the nerves. Yet another reason to educate our patients about monitoring and keeping our blood sugar levels low. And don't forget, we have the laboratory test, hemoglobin A1C, which actually can detect what our blood sugars have been over a period of time. That is a great indicator to determine if someone is predisposed or has prediabetes, high hemoglobin A1C levels. Another alteration in touch can be spinal cord injury. That can occur from trauma, such as diving into shallow water, a motor vehicle accident, gunshots, or during contact sports as football. Damage to nerves at the point of injury can impair nerve function below that point. This impairment leads to partial or complete loss of sensation of touch, pressure, and temperature. To diagnose an alteration in touch, we have to perform a full physical assessment and obtain a complete health history. We will also complete a neurological exam to assess reflexes and the ability to detect various sensations and temperatures. Diagnostic tests can include X-rays, laboratory tests, or MRIs. If we detect an alteration in touch, those clients will be referred to a neurologist for a more in-depth assessment and testing. Patients can also experience olfactory and taste disorders. The perception of the senses of taste and smell are intricately related. It's not uncommon for a problem with taste to actually be a smell disorder. Both taste and smell serve to protect humans from injury, allowing us to smell smoke, fire, gas, and taste foods or chemicals that should not be ingested. Taste and smell also stimulate the desire to eat. Humans have approximately 10,000 taste buds, but this number begins to decline after age 50. Bummer. We have taste cells that are stimulated when we chew and swallow our food, and that helps us to identify tastes as those cells send messages to the brain. The taste cells contain specific receptors that allow us to differentiate between sweet, sour, bitter, salty, or savory flavors. There's a small patch of tissue inside the nose that stores the olfactory sensory neurons, which creates our ability to smell. Olfactory neurons are connected directly to the brain, and each one has an odor receptor. Substances in the environment stimulate that odor receptor and send messages to the brain where the smell is identified. There are several causes of alterations in olfactory and taste. Up to 15% of adults experience a taste disorder, which can affect quality of life. Phantom taste perception, or a persistent foul taste when the mouth is empty, is the most common taste disorder. That would be awful. Hypogeusia is the decreased ability to taste, while ageusia is the inability to taste anything at all. Some of us may have experienced that when we had COVID in years past. A client who experiences a persistent, salty, rancid, or metallic taste is said to have dysgeusia. Most taste disorders occur as a result of injury or illness, but some people are born with them. Disorders in smell are the most common causes of taste disorders. Other causes include upper respiratory tract infections, dry mouth, head injuries, medication side effects, or deficiencies in vitamins and trace minerals. Clients who wear dentures can also experience an alteration in the ability to taste sour and bitter flavors. As we age, the number of taste buds decreases, and the quality in the remaining taste buds begin to shrink. Decreased saliva production after 60 also contributes to a decrease in taste. These changes can ultimately lead to poor appetite, weight loss, or malnutrition. Disorders in smelling or olfactory disorders can affect 1.4 to 62.4% of Americans, with more men affected than women. Olfactory disorders also increase with age. Common causes of olfactory disorders are nasal or sinus diseases, upper respiratory infections, or head trauma. Other causes of olfactory disorders include smoking, some medications like antibiotics and antihistamines. Clients who have neurologic conditions like Parkinson's disease or Alzheimer's disease are also at an increased risk for smell disorders. If a client presents with a taste or smell disorder, we usually want to refer them to an ear, nose, and throat doctor for further evaluation and testing. Clients who have alterations in olfactory and taste can have significant negative effects on their overall well-being and health. Olfactory and taste disorders can increase a client's risk for injury, depression, and malnutrition. So as nurses, we need to make sure we are asking our patients about any changes in their ability to taste and smell, especially in clients who are at increased risk for this disorder, like getting old. Several factors affect how a client receives and responds to sensory input. Some of the more common causes of alterations in a client's senses include older age, medications, and neurocognitive disorders. Some of these factors are modifiable, and a treatment plan can be implemented to either reverse or slow sensory changes. Other factors, such as age, are non-modifiable. However, there are actions that a client can take to reduce the risk of a sensory disorder. As clients age, their senses become less sharp, requiring higher levels of sensory input to trigger a response to environmental stimuli. Hearing and vision are the senses most affected by aging. Older adults may lose their ability to hear high-frequency sounds, and they may experience difficulties in differentiating between sounds. The eyes also undergo expected changes with age. Medications can also have adverse effects on the senses. There are more than 600 categories of medications that can cause ototoxicity. Ototoxic events can occur suddenly or slowly, be mild to severe, and be temporary or permanent. There are also medications that have been identified causing alterations in taste. Many medications can cause a bitter metallic taste in the mouth or alter a client's overall ability to taste. Medications can also cause dry mouth, which can lead to ulcerations in the oral mucosa, which will then alter taste and can cause pain. Cognitive disorders like dementia and delirium result in changes in perception, including sensory perception. Dementia is a general term describing problems with reasoning, planning, judgment, memory, and other thought processes caused by brain damage from impaired blood flow to the brain. Dementia occurs when neurons become damaged, lose their connection with the brain cells, and die. When a client experiences a loss of neurons with aging, although most aging clients have some decline of neurons, patients with dementia experience a much greater loss. Manifestations of dementia have a slow onset and are often initially overlooked. Clients who have dementia experience alterations in their perception of environmental stimuli. They have difficulties with memory, language, problem solving, and the ability to focus. Dementia has various causes, including Alzheimer's disease, and it is not reversible. Treatment is centered on alleviating symptoms and providing support to the client and caregivers. Delirium is a disturbance in mental ability, resulting in confused thinking and reduced awareness of the environment. Delirium is not a disease. It is a syndrome that has multiple causes and is generally reversible. Delirium usually begins suddenly over a few hours or days, with manifestations varying throughout the day. These manifestations or signs and symptoms include fluctuating consciousness, difficulty maintaining attention, disorientation, hallucinations, difficulty speaking, rambling speech, agitated, and unpredictable mood swings. Clients usually experience a worsening of manifestations during the evening. Delirium is often misdiagnosed as dementia, depression, mania, psychotic disorder, or as a typical response of the aging brain. Ensuring client safety, promoting independence, and providing emotional support are important nursing interventions for clients who are experiencing an alteration in sensory perception. Nurses play an important role in educating clients, families, and caregivers about medications, exercise, nutrition, and actions that decrease the risk of injury. Interventions for hearing include educating clients about promoting eye health and preventing injuries. For example, asking clients to wear eye protection when performing activities that could lead to eye injury. So when using hazardous chemicals, playing contact sports, using power tools, and using lawn equipment. Clients should also wear sunglasses that provide protection against ultraviolet light, even on cloudy days. The nurse needs to ensure that clients who have vision impairment have their required corrective lenses, like contacts or eyeglasses or reading glasses, and ensure that the clients wear them when needed. We should provide adequate lighting in our patient's environment and provide large print reading materials if necessary. We also may need to use a magnifying glass for reading, and we always want to face a client when speaking and make eye contact. For patients with severe vision impairment, nurses should announce their presence and ask permission to enter the client's room. We want to make sure we instruct the clients of locations of items in their room, like the call light. We want to encourage the client to request assistance with getting out of bed and ambulating. Clients may use assistive devices such as a cane or walking stick, a walker, or a service animal when ambulating. Clients who have visual impairments should have an environment free from clutter to decrease the risk of falls. Some clients may read Braille, and we can locate reading materials and menus in this format if possible. If patients have vision impairment, we need to explain what's on their meal trays, and we need to help open packages and cartons if needed. They should have grab bars in the bathroom and avoid placing area rugs, cords, and other objects on the floor at home. For our patients with hearing deficits, we need to educate them about promoting ear health and actions to prevent hearing loss. Prolonged or even intermittent exposure to loud noise can damage hearing. Therefore, we should instruct clients to wear ear protection when in noisy environments. When using headphones and earbuds, music and television should be played at a reasonable volume, and the client should take breaks away from the noise. Clients who work in areas of high noise should ensure they have adequate, well-fitting ear protection and monitor for manifestations of hearing loss. When we're caring for patients with hearing impairments, the nurse should always face the client when it's speaking and ensure there is adequate lighting. This allows the client to lip read and see nonverbal clues, including facial expressions and hand gestures. We should also minimize background noise by turning down the volume of the television or radio. We need to make sure if these patients wear hearing aids that they are in when we are conversing with them. To increase access to hearing aids, the FDA established a new category of over-the-counter hearing aids for adults 18 and older. Those can be purchased without formal diagnostic testing or a prescription, and they can help amplify sounds and improve hearing for adults who perceive that they have mild to moderate hearing loss. When the client does wear hearing aids, ensure that they are available, clean, and in working order. Some clients with hearing disorders can communicate with sign language, and every attempt should be made to use a sign language interpreter when possible. If one is not available, we should provide written materials or write down information for the client. Clients with speech impairments can become frustrated when attempting to communicate with others, so nurses should allow extra time to communicate with the client and exhibit patience and encourage the client to take their time when speaking. We want to avoid interrupting the client or finishing their sentences. We can use picture boards, a computer or tablet, or a paper and pen to assist with communication. There is also speech therapy available for patients. Alterations in touch can be prevented by encouraging patients to avoid activities that increase the risk of a spinal cord, like diving into shallow water. We can encourage patients to wear a seat belt when they're in a car, wear a helmet when biking, skateboarding, or playing contact sports to avoid spinal cord injuries. Handrails when walking on stairs, non-skid mats also help minimize the risk of a fall and spinal cord injury. Patients who have diabetic neuropathy or a decrease or absence in sensation in their lower extremities should be educated about foot care. These patients should inspect their feet every day for cuts, blisters, areas of redness, or warmth and report these to their provider. The nurse should assist the client to examine the bottoms of the feet if the patient isn't able to do so on their own. These clients need to be cautious when ambulating to avoid injury to the feet or toes, and they should wear closed-toed shoes and avoid walking barefoot. Patients with diabetic neuropathy should also follow dietary instructions and take all medications in order to manage their blood glucose levels, because doing so can slow the progression of that neuropathy. Poor dental hygiene and dental caries can cause alterations in taste. So as a nurse, we should remind clients to perform oral hygiene frequently and see their dentist regularly. We can also encourage patients to avoid smoking or using tobacco products because those can damage the ability to taste and smell as well. Good oral hygiene includes brushing the teeth at least twice daily and flossing daily. If our clients wear dentures, we want to make sure they are kept clean and notify their dentist if they have any issues with how they fit. Clients with taste disorders can be instructed to choose slowly and season food with spices to enhance flavor. Another important thing to do for clients who have smell disorders is to install smoke detectors in their home, as well as carbon monoxide detectors if needed. This slide goes over interventions we can provide for clients that have sensory deprivation. They may be in the room, they may not have a lot of visitors, so we can provide stimulation. If they can't hear, we can amplify their phones. We can use pleasant aromas to help their senses to relax. We can increase the amount of touch. We can use a hand on the knee or a hand on a shoulder to give them some sensory input. A lot of these people haven't had physical contact. We can ensure that their assistive devices like hearing aids, glasses, canes, walkers are available to them. We can encourage their family to bring flowers and pictures to help provide stimulation and things for these patients to look at and see. And then we can provide various textured objects so patients have something to feel and use their tactile senses on. If a patient has sensory overload, we're going to do some of the opposite things that we would do for sensory deprivation. We're going to minimize their stimulation. They could be in a private room, have the lights low, silence pumps and noises. We can provide them with orientation clues so they know where they are and what time it is. We can limit the visitors, reduce unpleasant odors, make sure their pain is controlled, and we can schedule sleep. That's going to help patients that are totally overloaded with tactile, visual, and hearing stimulation. Alterations in the senses can have significant effects on a client's overall health and well-being. Common alterations in vision include refractive errors, cataracts, glaucoma, diabetic retinopathy, and macular degeneration. There are 3 types of hearing loss: sensorial, neural, conductive, and mixed. Smell and taste disorders often occur concurrently. Age and neurocognitive disorders increase the risk for sensory impairments. Diagnosing a sensory impairment includes physical examinations, neurological assessments, and diagnostic testing. Nurses play an important role in assisting, educating, and supporting clients who have sensory impairment. And ensuring the client's safety is the nurse's priority when caring for clients who have sensory impairments.